District, Public Health District number 1 for the state of Idaho. The secretary will record, I think we're here 6 out of 7.
Mr. Chairman,
Yes.
I just received a message from Dr. McLeod. He's with the patient. He'll be 10 to 15 minutes late.
All right. He'll let us know. Sure, when he's able to join us. Stand. We pledge allegiance to the flag.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. You may be seated. I checked the proper authorities and we have no public comments at this point. So we will go right into our consent agenda. We have the minutes of March 25 and the divisional reports, and there was one contract for tobacco prevention. Any comments on any of the items in the consent agenda?
Mr. Chairman,
Yes,
I would move that we approve the consent agenda as submitted.
thank you. Is there a second?
I would second the motion.
We have a motion and a second. All in favor then of passing the consent agenda as is presented in your packet? All in favor say aye.
Aye.
And opposed, no. And we have approved the consent agenda. Moving right into item number 5 on the agenda, we have Mr. Jeff Lee with us. As Jeff comes to the podium, let me point out how this is going to work just now. Number 5, program update, epidemiology, and the annual CY 2020 report. Jeff will be giving that. Also, when you go down to number 6, the first portion of number 6, COVID-19 status, Jeff will continue on that first half, and the second half of item 6, the immunization update, that will go to Mr. Don Duffy. In the meantime, Jeff, you have the floor.
Thank you, Mr. Chairman.
That's the one on the bottom right.
That's not the first one.
Isn't it?
No.
That one?
No, yeah.
Oh,
There we go. Thank you.
I'm not sharing it though. I don't think. Now.
I'm sorry. This is the COVID-19. We want to.
Okay. Another shot. This one.
Yes.
Sorry, Jeff, it's a really weird angle over here.
That's okay. All right. Can we go ahead and just move to the next slide, please? Okay, so 2020 was a strange year for general reportable diseases. They didn't stop while COVID was occurring. And the numbers that I present here today are provisional as we complete out some of the cases that we weren't able to do data entry on during the height of COVID. But this slide represents the top 10 reported diseases. This represents roughly almost 99% of the reported diseases. STD, chlamydia was our number one reportable, which it is every year. Hepatitis C was number 2, again, as it was every year. The number 3 spot tends to vary, but gonorrhea has been in the number 3 spot for a handful of years now. We are seeing HIV in the top 10, unfortunately, as well as pertussis has moved up, but not as bad as it could have been. I think a lot of outbreaks, and we'll get to the outbreak page, you'll understand what I'm talking about, but a lot of the outbreaks that could have happened didn't because of measures in place to protect it against COVID-19 transmission. So that was a good outcome for that. Next slide, please. So this is just representing the actual numbers of cases reported from each of the counties as an aggregate. What I want to point out is that Shoshone County and Benewah County are among the lowest in the district for the number of cases. Next slide, please. But based on population as an incidence rate, they are the highest disease burden counties in the district. Their small populations have also affected COVID-19 variability over the course of the pandemic. But we also continue to see, I haven't come up with a good name. I don't want to say routine diseases because we don't want them to be routine, but our normally reportable diseases continue to represent problems for those particular counties, which are medically underserved. They're more rural. They've got a lot of challenges there. Next slide, please. It's hard to believe that we had anything other than COVID-19 outbreaks. Salmonella played a big role. These were pockets of salmonella. Fortunately, the total number of people affected by this was limited to 19, which is great. And I have to admit up front, the extraordinary occurrence of illness was an outbreak assigned by the Bureau of Communicable Disease Prevention. They volunteered to help us with some of our caseload while we were at the height of COVID-19 activity, where we were seeing 300, 400 cases per day, and all of our staff was otherwise occupied. So this was 2 individuals, and I am still looking to find out what it was an extraordinary occurrence of. I don't have the specifics on that. The others were, as indicated, Salmonella and E. coli. The Kootenai County, Boundary County outbreak involved 12 people, 2 in Boundary County and 10 in Kootenai County. Next slide, please.
Can we go back for a second, please? What are those that you got the year and?
Those are outbreak numbers. So when we have what we consider to be an outbreak, it meets the criteria, we call Boise, and they assign an outbreak number. Actually, COVID-19 has an outbreak number, 2020-018. So each of these are unique outbreak numbers for the year 2020. And this does a couple of things. This allows for tracking at our level, at the state level, and analysis. It also allows us to submit specimens to the state lab at no cost to anybody, the physician, the community, other than the shipping costs, none to us as well. So this is just a way to track and account for different outbreaks. So influenza, you've seen this in the earlier iterations. These are the previous 3 years. The green down at the bottom is the current year. 2020 is, 2019, 2020 is the red. And 2018, 2019 is the blue. You can see with 2019, 2020, at the point where COVID-19 became big enough of an issue that we had to back burner flu surveillance around week 6 of 2020. Next slide, please. So just a 3-year comparison on deaths. So far this season, and the season isn't over, surveillance isn't over until the end of May. But as far as what we would call the start and ending of a flu season in our area, this year's flu was a non-starter. We require it to move above 10% positivity rate for 2 consecutive weeks to call the start of the flu season, and fall below that 10% positivity for 3 consecutive weeks to end it. Well, we've never gotten much above 1 or 2% so far this season. So we will continue to monitor through the end of the surveillance year. We did have 6 deaths in the 2019-2020, and up there it says 0 to greater than 50 years old. We had 3 age categories, 0 to 18, or it's under 18, less than 18. Then 19 to 49, and then 50 and older. And those age groups are identified by the state for death reporting. And we had 6, and we had at least one, we had 1 in the under 18. We had 2 in the 19 to 49, and then we had 3 in the over 50. And then 2018, not 2019, all of them were older than 18 years of age. But not a lot of deaths. No death is good, but comparatively speaking, we didn't have a lot of deaths those years compared to the 2017-2018 year, which we had 36 deaths that year. That was our tough year. Next slide, please. And that's it for the epi summary, real quick. And we can go ahead and go to the other.
Probably easier said than done.
That last one looks, yep, that'll work. Awesome, thank you.
Check, I'm gonna see if I can make that thing go away. Is there an option there?
Mr. Chair, I think what Jack is looking for is the COVID summary.
This is the COVID epi summary.
Oh.
Okay, starting with this current status up to date, over 140 million cases worldwide, with almost 800,000 reported in the previous 24 hours. That's on a global scale. We've had over 3 million deaths globally, and 11,000 were reported in the previous 24 hours. Sorry, it's time to be here. Next slide, please. Right, excuse me?
Sorry.
Okay. Cases nationwide are over 31 million. with almost 60,000 reported in the previous 24 hours. And unfortunately, we've moved past the 500,000 mark for deaths. But the number of deaths reported in a 24-hour period have gone down, which is good. Next slide, please. In Idaho, to date, we've had almost 186,000 cases. Very happy to see that statewide, we've only had 294 cases reported in the last 24 hours. Not too many months ago, that was our typical day, just here in District 1. We have had over 2,000 deaths in the state. Next slide. And almost 300 deaths here in Panhandle Health District. So we've only had 49 cases in the last 24 hours with a daily average of under 30 cases, which is great. As a result, we have decreased sizes of our investigation and data teams to compensate. All of the counties, with the exception of Shoshone County, and it's just a localized increase. Again, smaller counties, their populations, it doesn't take a lot of cases for that to show a big increase in the incidence rate per 100,000. But we, at this morning, at our morning meeting, are keeping all counties in the minimal or yellow category at this time. Although Shoshone has jumped up, that was due to about 11 cases that occurred a few days ago. Those were not a localized cluster, that was general population with an age range running from teenagers to mid-70s. So, but the good news is that minimal means minimal community transmission right now, which is very good news. Our positivity right now is at 6%, which is also in the yellow or minimal category, 8% being the threshold up into moderate or orange. Again, by county breakdown, we did see a jump up in Shoshone about a week before we saw those 11 cases. That's pretty typical. There's a delay between the time of testing, time of reporting, and then on to time of hospitalization or death. Next slide, please. As you can see, we've come way down from where we were in December timeframe. But I would point out that two things. One, we discontinued weekend operations as the number of newly reported cases came down to a manageable level for our teams. So the little spikes that you see after the blank columns there are Mondays, where we're looking at Saturday, Sunday, and Monday new cases. So that accounts for those little spikes. But we are seeing a little bit of a trend. It's not a big trend. Actually, it increased our daily average from 23 new cases a day to 27 new cases a day on average currently. But it is a trend that we will watch because other parts of the country are talking about moving into a third or fourth wave, depending upon how they're counting it in their state. Next slide. This is a graphic representation of the incident rate, the 7-day average incidence rate per 100,000. And you can see where the black line is Shoshone County. That popped up about 2 days ago, and brought them up into the orange or moderate category. The rest of the counties are still in the minimal or yellow category and have been fairly steady there. Some fluctuation in Bonner County, but it really didn't leave it up in the orange at all. So, next slide, please. And then this is a positivity from the Sentinel testing site. You can see back in December, in early January, we had some peaks that were up around 30% or better for positivity rate. And here towards the right-hand side of the end of the graph, you can see we're down actually less than 10% and below the 8%. That would be a transition for positivity rates. It did come up a little bit in the last couple of weeks from its low, but it seems to have stabilized. We are seeing a decreased demand for testing. One of the things I would caution, though, is that we are seeing variants. We have at least 4 variants. One of them, I don't know if I would count the 2 California variants as 2 distinct. They're very, very close to each other with the same capabilities. Next slide, please. So we have had 9 variants detected. 5 of them have been the UK variant, which is estimated to be about 50% more transmissible than the original SARS-CoV-2. We've had one of the California 427 cases. That was actually in a healthcare worker and fully vaccinated. So that is also one of our vaccine breakthrough cases, was identified as the California variant. And 2 of the other California, the 429, and then the last one, the B1526, is called a New York variant. That is not a variant of concern at this point. It's called a variant of interest. But it was a variant identified in our area, so I'm including it in the report. We've had 22 vaccine breakthroughs, and that can be a misleading term. These are people that have been fully vaccinated, and it's been at least 2 weeks since their last vaccine. But when we have a vaccine effectiveness around 90%, we expect possibly 10% of the population is not going to be covered as well and may become infected and have symptoms. The objective with the vaccine is to not just minimize the number of new cases, but to minimize the symptoms and illness of individuals that have it. And so far, it appears to be doing that. Right now, we've sent 7 of these to the state. The reason that only 7 have gone to the state for sequencing is different labs are using different types of tests. Some of them don't lend themselves to do the genetic sequencing, and some of them don't keep their specimens for very long, and so we aren't able to request that they send those down to the state. We're still waiting on 3 specimens that went down on vaccine breakthrough to determine whether or not they're variants. Mr. Chairman, I'm complete. I yield the floor.
Thank you. Thank you. Any questions from board members? Okay, to his report, any comments, questions?
What do you want to comment?
I have a question. Can you hear me, Mr. Chairman?
Okay, Dr. McLandris, is that your voice?
Yep, now I can hear you better also.
Okay,
I have a
yes,
question
you
for Jeff.
have the floor.
Do we know the 7-day case positivity per 100,000 in Spokane County?
I can look that up. I don't have that number in front
I
of me.
possibly missed that, but I don't. Do you know those numbers?
I don't have them in front of me. I can look those up and get back to you on that.
Okay. All right, Dr. Banks?
Just like to reiterate, Mr. Chairman, that a positive case is not a sick person. A positive case is just a positive case in a test which is not licensed. It's apparently testing for human RNA. And I'm surprised it doesn't find human RNA all the time. It must be targeting a particular type that's only found in people with respiratory infections, which seems to be what I have read. In any case, the whole discussion of this virus, which the best evidence I've been able to find is that it's questionable whether it even exists. The case numbers are just positive tests. People that are dying of the same diseases they died of before. They're now being attributed to COVID, but that doesn't mean that they are. Heart disease has virtually disappeared here in the United States. Influenza has disappeared. They used to be leading causes of death. Now they're all attributed to COVID. So my position is that this has been a misleading misadventure on the part of our health care authorities.
Any other comments or questions? We have time. Do you have a question or comment?
Yes, I was just wondering if you could explain vaccine breakthrough for me again. I didn't understand the term.
Sure. No vaccine is perfect. If it would cover 100% of everybody, but people are different. They have different immune systems, and it's different at different times for them. So you've heard terms like efficacy and effectiveness. Efficacy is basically what they can demonstrate in a laboratory as far as how well a vaccine prevents a disease from happening or reduces the risk from that disease. Effectiveness is the measure applied out in the real world. And the two mRNA vaccines, the Moderna and the Pfizer vaccines, were about 95-96% efficacy rating in the laboratory. And what we're finding out in the real world is it's about 90%. And so there's an assumption that we're going to see probably 10% of the people that are fully vaccinated, where it doesn't cover as well, doesn't completely prevent disease, but does in fact reduce the severity of that disease. So when we talk about vaccine breakthrough, we're talking about fully vaccinated people who have had it's been at least 2 weeks from their last vaccine. They become exposed to COVID-19 in any one of its variants, and become infected, become symptomatic. And we want to gather that data because that's continuing to inform us on, is it really 90% effective? What percent of the population is not having complete coverage from this vaccine? Did that answer your question?
So are we seeing more cases of COVID after people are vaccinated than we did before
No.
people were vaccinated?
No.
All right. Thank you.
Thank you, Jeff.
Thank you, sir.
Indeed, I have one other question, but I have a suspicion it will end up in Don's lap. And this is relative to the clinical services and the term Janssen vaccine. Is that something you want to talk about, or Don, you want to talk about?
Well, the Janssen vaccine
Well,
is,
I just was not that familiar with that particular word.
I'll be talking about that in a moment.
All right, you're off the hook.
Thank you, sir. Thank you.
All right, Don, you have the floor.
Thank you, Mr. Chairman. I appreciate the opportunity to share with you the great work
that's happening with PhD and multiple partners in the distribution of the COVID-19 vaccine. And let's move right to Mr. Chairman's question about the Janssen vaccine. There are 3 manufacturers currently used in our area. They are the Pfizer vaccine, that's a 2-dose vaccine. There's the Moderna product, that's also a 2-dose vaccine. And then third, there's the Janssen product, Johnson & Johnson, also known by. And that is just a 1-dose vaccine. And we have used that very successfully until recently. A hold has been put on, or it's being called a pause on distributing that vaccine due to some blood clotting of 6 to 8 individuals that have been reported around the country. The FDA will be meeting, or ACEP will be meeting again today to discuss whether that product will be renewed. I suspect that it will be renewed. To answer your question, Mr. Chairman, that's the third of 3 vaccines that can be used for COVID-19 infection or prevention.
I just didn't realize Johnson & Johnson was, being used interchangeably with that Janssen?
That's correct.
Thank you.
You bet.
Just my ignorance.
No problem. So as of today, these statistics are for the 5 northern counties of Idaho. 152,178 doses have been delivered. Nearly 120,279 have been administered. It's a little short of that. Some of our partners are holding a little bit in inventory. But of what's been administered, Panhandle Health District has administered 26%, so a fourth of those has been done by our personnel, National Guardsmen, and MRC volunteers, all associated with Panhandle Health District. As of today, 58,000 or 29% of the population 16 and older has been fully vaccinated. So going back to Jeff's comment that there's been 22 breakthrough cases, that's out of 58,000 that have been fully vaccinated to date. 72,000 individuals, or 36% of our population, 16 and older, have received at least 1 dose. And again, obviously, many more are waiting for their second. There has been a precipitous decrease in demand for the vaccine. In fact, currently in our inventory, we have 28,000 doses in inventory, due to the drop in demand from not just coming to Panhandle Health District at our sites, but all of our partners. So we've made the decision to hold on any additional deliveries from the state of Idaho of vaccine until we work down that inventory. We have tremendous partners in assisting us with this process. We have 39 locations throughout the 5 counties where an individual can be vaccinated. We're doing a little transition. We're transitioning from these pods or permanent vaccination sites to what we're calling mobile vaccination teams. And if I could characterize by saying it's no longer build it and they will come, it's build it and we go and find them. So we're trying to be a lot more mobile in our vaccination, reaching out to the public in all corners of the 5 northern counties to provide people the opportunity, if they wish, to be vaccinated. We currently have, for example, some of the locations scheduled is North Idaho College, Kootenai County employees, and all the way up to the Lucky Friday Mine in Mullen, Idaho. So again, we're going to all corners of our district to give them the opportunity to be vaccinated. We've also opened up our clinics. Today is the first day that we have an evening clinic. We did it when we were vaccinating the schools. But we will have regular hours in our evenings, and also soon we'll be starting to open Saturdays as an opportunity for times that people can get vaccinated, trying to reduce as best we can barriers for receiving the vaccine. We also are grateful for Coeur d'Alene Fire, Coeur d'Alene EMS. They are deploying to do vaccinations for the homebound in any county in the state of Idaho. Now, they were using the Johnson & Johnson product or the Janssen product, and we hope that that'll be available again to us soon so that they can continue to renew that. As you can see, it's much easier to do a single dose for our homebound than have to go back and do a second dose. We Due to the decrease in demand, we're also, some of our permanent sites, we are going to be ending those relationships, and those are in counties of Benawah, Shoshone, and Boundary. And we'll be moving vaccination efforts into our PhD clinics in those counties. I would suspect in the next 3 to 4 weeks, we may be doing the same in Bonner County as demand is decreasing. In Kootenai County, we continue to vaccinate primarily at the fairgrounds. Of course, again, there's 39 locations, so there's multiple other partners even in Kootenai County, as well as in all of our counties. But due to the fairgrounds has been a fantastic partner. They've been extremely flexible for us to do large-scale vaccinating. But as you know, spring and summer is coming, and that'll be a busy place, and it'll be challenging for us to efficiently vaccinate at the fairgrounds. So we're moving to other locations here in Kootenai. We're moving toward possibly North Idaho College as a location to vaccinate, moving away from the fairgrounds. And I just want to say again, these partners that we deal with in this community have been nothing short of incredible and flexible. They understand the health need that we're facing in this community and are working right alongside of us to make sure that folks get vaccinated or have the opportunity to be vaccinated. A couple of variables we're kind of watching that could change things too, primarily as Jeff pointed out about the variants. So far, so good with that. We'll kind of see where that goes, if that's going to change how we do our business. We also, as you I'm sure have also heard, that some of these larger manufacturers, Pfizer most specifically, is talking about the potential of a third dose needed or a booster dose. And if that happens, that will require a lot of effort on PhD's part to make sure that individuals have the opportunity, if needed, for that third dose. But the jury's still out on that. We're still waiting to hear back from them whether that's going to be a suggestion for the vaccination process. And Mr. Chairman, that ends my report, and any questions I'd be happy to entertain.
Okay, from the board, do we have any questions for Don and the report he has given?
Mr. Chairman.
Dr. Banks?
Don, could you comment on the observation nationally that 60% of new positive cases have been in vaccinated people?
60% of vaccinated folks,
No,
60% of positive cases have been people. I cannot comment. That would be a good question for Jeff.
Mr. Chairman,
Yes.
I believe we have Dr. Dow on Zoom, if you would like her to comment on that. Karen Yao, our virologist. Karen, this is Laura. Can you hear me?
I can't send it.
Well, here's another question, Mr. Chairman, while we're waiting. What do you know about blood clots in these various vaccines?
I know very little. All I have read, Dr. Banks, has been there's been 6 to 8 cases of blood clots with the Johnson & Johnson product thus far. And there have been hundreds and thousands of doses of that particular product that's been administered. And as of today, there's been 6 to 8 individuals, but the specifics of the blood clotting, I could not respond to. Getting back to your question regarding the 60%, again, as I mentioned earlier, today, we've had 22 breakthrough cases, and there have been 58,000 individuals just in the 5 counties that have received both their doses. So I'm not sure about the 60%, but speaking of just our 5 northern counties,
that 22 is a very small number compared to the 58,000 that have been vaccinated.
Yeah, I believe the comparison would be of total new cases, how many have been already vaccinated? Do you understand the difference?
Alan, you'll need to get much closer to your mic if those in the outlying area are able to hear you.
Don't want to get too close. Okay, so what I have read is that 60% of the new cases are among those who've already been vaccinated. And so my question was, could we get an explanation for that? My guess is probably can't be explained, but I'm sure people are looking right now. It's just interesting. I guess that would be, what would you call it? That would be a breakthrough case then, because they've already been vaccinated, but yet they test positive again.
Mr.
Yeah, and I
Chairman,
would add to that, we're getting right now, we get somewhere around 40 to 50 cases a day is what we're dealing with right now, and we've had a cumulative total of 22.
Okay, Don?
Mr. Chairman, I believe Dr. Yao is ready to respond to that. Karen, you're on.
Hi, Dr. Banks. Would you be able to provide us the source of that information? Because I've been following this very closely and I have not heard vaccine breakthrough as 60% of the vaccinated people. And the only possibility is maybe you're confusing that with what we're seeing in Brazil and India, where people have been infected with the wild type virus and that they're being reinfected with variants. But those are the only reports that I'm aware of.
I will be happy to forward you the link when I get to my computer and I can pull it up.
Right, thank you.
Anything else? Any other questions for Don? If not, thank you, Don,
Thank you, Mr. Chair.
for the report and all the work your colleagues are doing. Yes. All right, let's hear from our trustee. Glenn, what do you have for us this afternoon?
Mr. Chairman, the primary item of discussion and interest for the Executive Council has been regarding the current legislative session, and they've been back in session for just over, 2 weeks, right on 2 weeks now. And during that time, there have not been any major developments in House Bill 316, which is the item of interest for the health districts. It proposes changes to the funding of the health districts, proposes changes to granting the county commissioners the ability to reject a mandate or emergency order from the health districts and those kinds of things. So there have not been any major developments or changes that I'm aware of. So,
Well, my question on this 316, when you mentioned that county commissioners having the ability to reject, but doesn't this also make it their responsibility to put this into effect if something were needed?
as far as approval, no, the legislation just states that they have the ability to not approve it for their county specifically.
Okay. And not for them to step up to the plate.
Well, they would be considering it, obviously, and making a decision on it. They'd have to advise the health districts as well on their decision, so.
And you mentioned this is of utmost importance to the health districts. It seems like it should be of equal importance to the county commissioners.
Oh, yes. Do that.
So what are you hearing among the county commissioners? Do they want this to go through? It seems to not be going anywhere right now.
My understanding, at least from Bonner County, is that yes, they approve, they support the proposed changes. But I haven't heard a whole lot more than that. I think that the county commissioners obviously like to have a say and have the power to approve or disapprove things like a mandate, especially the one we just rescinded during our last meeting. They would have liked to have the opportunity to say, no, that won't be applicable in our county. So I think they're supporting this proposed legislation.
The only thing I see about that, which is fine, if that's what they want to do, but if I had the feeling that the county commissioners were going to reject anything that we did, I would be prone not to do it anyhow in the first place.
Well, that's why we like to have county commissioners on our board, is so that we can discuss proposed, mandates or emergency orders. Those things have to go into effect quickly if there's an epidemic just pops up.
Sure.
In the health districts, we have the expertise and personnel to determine this is a major threat. We need to put into place an emergency order, and we would also need to include or try to persuade the county commissioners, this is the situation, this is what we are going to mandate or do as an order, and have them evaluate it. They can ask their questions and decide to approve it or not approve it.
Well, it's going to be really interesting how this finally turns out.
It would be.
Because the way it is right now, I don't have a real strong position one way or the other. If they think they have the right answer, more power to them.
And obviously, them not having medical expertise unless they are a doctor, they're going to be consulting and asking a lot of questions before they make the decision, I'm sure.
Well, thank you. Carry on. I didn't mean to.
Yeah, other than that, the question would be, when would this legislation, if approved, go into effect? Would it be the calendar year? Would it be 3 months later in March? Would it be 6 months later in July? In my opinion, I think Laura's, is that it should be delayed, if approved, to later in the year so that the counties have the ability to plan it into their budget. Because they will have to be, picking up the tab for more of the funding, since the state's funding will be withdrawn. And they're gonna have to be using the catastrophic healthcare funds and other things. And there's a lot of question marks still, I think, for the legislatures on how this will happen and be effective, should it be implemented. So that's all I have.
Sure. And as you can tell by the way we talk, it's really hard to talk about it.
Yeah. without more information.
Thank you. Indeed. Any other comments or questions? Yes, Laura?
Mr. Chairman, yes, thank you, Glenn. Just to clarify, I think we're talking about the two different bills. The one is already passed in its law, 1060, Senate Bill 1060 that Senator Rick introduced, in which, as Glenn was referring to, and you were referring to, Mr. Chairman, if a health order is put into effect, which, this is the first order we've ever written, but were that to happen again, were there to be another situation in which the health board made a decision for the good of public health to institute an order, it would have to be within, I think it's 7 calendar days, be approved by the county in which it takes effect. In the case that we just had, it would have to have been each of the counties. So the commissioners are essentially making those health decisions, or which will be our job to explain to them, and then the decision will be theirs. And 316, what it would do, which again, we don't know where it's going to go this session, is it would essentially eliminate the indigent fund. And with that savings, the counties would be asked, and they estimate in FY22 it would be $6 million in savings, and in FY20 each year after it might be $12 million in savings. That the counties would pick up the state funding using those savings. And we'll just see what happens.
Okay, does that conclude what you have for us today?
Yes.
Thank you very much. All right. We want to hear from and just like that, she appears.
Hello, good afternoon, everyone.
Hi, Christine, you have the floor.
Thank you, Mr. Chairman.
Need this?
While Christine is getting set up, as you well know, our director was on vacation last week. And last week we had a couple of emergencies come up. Christine was left in charge in the absence of our director. And Christine rose to the occasion and in a very professional manner handled the issues that fell to her lap. Thank you, Christine, for, you probably don't want to repeat that week right away, but thank you for doing that extra work for us.
Thank you, Mr. Chairman. But Dawn and Joe were also there at the ready too. We were all involved. As we do with each board meeting, for the financial presentation, we'll start with the cash balance. We're reporting for the 9 months ending March 31st. Our ending cash balance is $4,900,000, which leaves us 4.63 months in reserves prior to board committed funds and program restricted funds. Once those are removed, the board committed funds are currently $318,000. Program restricted funds are currently $268,000. Once those two items are removed, we have 4.07 months in reserves. Are there any questions on the cash balances?
Do you anticipate that you're going to stay up into the 4 months of cash reserve?
No, Mr. Chairman, I don't. Depending on what the cash balance looks like, the end of May, I'm going to propose that we make a large principal payment on the Hayden facility and pay down or pay off the Sandpoint facility. Not much has changed between March and February when we last met. Our fees and contracts are under budget by $534,000. Most of this is due to home health related fees, as Don presented last month. He discussed some of the challenges, and some of those challenges were related to COVID. Part of it is also due to the clinical fees being down because we haven't been able to see the patients. And we have had the positive effect of environmental fees being increased due to the strong economy, the strong construction economy. So overall, revenue is down under budget by $541,000. Total personnel expenditures are under budget by $621,000. Total operating expenditures currently under budget by $604,000. Total capital expenditures under budget by $80,000. We can anticipate that we will probably see that will be over budget by the end of the fiscal year because ICP has been under budget in their overhead expenses. They've elected to accelerate the purchase of a new truck and 2 trailers. It's no cost to the district, they're just shifting from operating expense down to capital. Total trustee benefits are over budget by $51,000. As we've previously discussed, the majority of that is the payout for the Governor's Trust Fund in the ICP program where that was transferred to the city of Kellogg. So we currently have budget-wise in excess of $713,000, which translates to an excess of $1,140,000 in cash once we adjust for the decrease in accounts receivable. Add that to our beginning cash balance, we come back to our ending cash balance of $4,900,000. Are there any questions on the budget to actual as of March? There being no questions, we will move on to the budget presentation for fiscal year 22.
Mr. Chairman,
Yes.
Christine, did you bring copies of this for the board?
No, I I did not. I apologize. I thought they were,
I'll be right back.
thank you, Jill. I thought they were down here.
I'll use these.
I'll get started and then I'll pause on the worksheet so that Jill can give you the packets, because there's a couple of PowerPoints that'll be much easier if you have the hard copy in front of you than looking at the screen. So as we usually do, we'll talk about the funding formula, the population, property valuation changes, and the county formula, and then the budget summary proposal. Now, this has been a difficult budget to prepare, not knowing what's going to happen with the House bill. So when the budget was prepared, I prepared it based on the fact that it would pass, knowing that we may definitely have to revise the budget.
Christine, if I could just add, don't feel alone on this. School districts, county commissions, all of these agencies are having the same problem that you are having right here at the health district. So it's no fault of yours or anyone's on the health district. It is a general thing across the entire state of Idaho.
I can imagine for some of the very large agencies that it would be very problematic for them, very challenging. Thank you. So high-level review, the state matches 67% of the county contributions per state code 39425. This you may like to look at your hard copy of, and I believe I will too. So House Bill 285 proposes that the health districts will get $9,745,000. So if we remember here, 67% of that amount is calculated based on the county contributions, and 33% is going to be made up of these other areas down here. And I apologize, the mouse is not working very well, so my driving is quite erratic here.
He's not ready, you think?
I'm not sure what we need.
The cursor is disappearing on the screen.
You want
It's making.
that?
Trying to get down to the minimum, I just wanted to point to each one. So here we have, oops. So we have our minimum category, which is actually the infrastructure, and it represents 18% of the 33% allocation. If you recall, we have a component that goes to poverty, which represents 14% of the 33% allocation. Population is 50% of the 33% allocation, and the HIPSA, health professional shortage area, represents 18% of the 33% allocation. So for District 1, the amount that we'll be receiving based on the county contributions is $829,000. We'll be receiving 85 for the infrastructure component, 27 for poverty, 244,000 for population, and 92,000 for HIPSA, for a total of $1,299,500 for the state appropriation, assuming House Bill 285 passes. That's an increase of $10,300 over the prior year. Now, the difference between this budget that we're presenting today and what you saw in March is, in the March budget, I did not include the $1,299,000. That budget that I presented in March just included the fiscal year 21 appropriation amount that we had received. And there's only about a $30,000 difference between the two. So next page is the budget proposal. So the revised budget for fiscal year 21 is $14,653,000. The proposed budget for fiscal year 22 is $14,191,000, a decrease of $462,000. The majority of that decrease is related to COVID. We're anticipating that we'll be able to wind down on the COVID response effort. So that makes up the majority of the difference. If we look at salary and wages, salary alone is a decrease of $345,000. Again, we anticipate that a majority of the decrease is related to COVID. However, there's a 4% increase based on the governor's recommendation for a CEC increase. You'll see that fringe benefits have also increased by $75,000, and that's related to health insurance premiums increasing. We're going from $11,650 per position to $12,930 per position. Overall, the personnel budget includes 137 FTEs, of which 18.7 are related to COVID. If we adjust for that, it brings it down to 118.35 FTEs compared to fiscal year 21's FTE budget of 119.06, which is a 0.71 increase in FTEs. Looking at operating expense has decreased by $291,000 compared to the fiscal year 21 budget. Again, a large amount of that is COVID, but also what we've included in this is in fiscal year 21, we did not have the HRSA grant, which is a $300,000 a year grant. So there's approximately, in that amount, approximately $120,000 that's been included in overhead expense for fiscal year 22.
Christine, can you remind me what HRSA stands for?
Health Resources and Services Administration.
Got it.
The total capital expenditures, it's an increase of $21,528. So what we've included in the fiscal year 21 capital budget is $100,000 in security updates for the St. Mary's and Kellogg facilities. We had actually included that in the fiscal year 21 budget, but we've been unable to get those installed and implemented, so they're a carry forward. We've budgeted 2 vehicles for fiscal year 22, same as what we budgeted in fiscal year 21. We've also included $134,000 in upgrades to the Bonners Ferry facility, and Dawn had presented on that early last fall, late summer. And then the big item is the capital expenditures or the principal payments related to the Hayden facility. So we've budgeted $337,000 in principal payments. If you recall, the loan is currently at 0% for Hayden. That loan resets in 5 years, so it's due to reset in September of 2025. It reset earlier this year. So the amount of payments that I've budgeted is the principal payment for Hayden as it currently stands, but assuming that Sandpoint is paid off in June, and it would be paid off in September, October anyway, but if we expedite that and pay it off in June, I've included the Sandpoint payment of $14,325 and budgeted that amount for a total of $337,000 for fiscal year 22. If we make that payment, in addition to a $225,000 principal payment lump sum for this year, that should put us in a position to be paid off right at the 5-year mark, right when it's time to reset. Now, there's nothing that says that we can't pay more a larger principal payment, but I've budgeted based on what gets us to that 5-year mark. Looking at the revenues, nothing has been budgeted for reserves of board committed funds. We've budgeted $18,000 for program advances, program restricted funds. Licenses and fees have been budgeted at $2,032,000, an increase of $382,000. We fully anticipate that environmental fees will remain strong. We anticipate and hope that we'll start seeing more patients in clinic. That's what's driving that $382,000. The health services, excuse me, I spoke prematurely. The 382 is related solely to environmental. Health services, we are anticipating an increase in clinical fees, but we also anticipate a decrease in home health, again, for the reasons that Dawn presented last month. Contracts and grants will decrease by approximately $371,000, and that's solely related to COVID. We anticipate that our general contract revenue will stay equal to what it has been, plus we need to remember that we're including the HRSA grant of $300,000, which was not included last year. Donations and other, an increase of $1,800, and what donations and other include is, of course, the donations, but also what's included in there is P-card rebates. So anything that we're purchasing using the state credit card, we get a rebate on it. So that's factored in there. Interest, well, we know interest rates have tanked. So we budgeted $27,000, which is a decrease of $6,000 compared to prior year. We've assumed that county funding will remain the same. We're not asking for an increase. And again, we're anticipating or budgeting based on House Bill 285 passing. So we've included $1,299,000 for the state appropriation component. Again, that brings us back to a total budget amount of $14,191,000. So the county component is calculated based on 70% related to population and 30% based on property valuation. So here we have the county statistics. We'll start with population. Total population for the 5 counties for fiscal year 22, based on FY20 fiscal year 20 population numbers, is 247,163 compared to 245,861 last year, an increase of 1,300. So you can see that Benoit dropped by 58, Bonner dropped by 68, Boundary increased by 65, Clotting County increased by 1464, and Shoshone County decreased by 101, for a total change of 1,302. So our property valuations for fiscal year 22, in total, we have 34,466,136,824 compared to 30,992,763 prior year, an increase of 3,473. We can see the majority of the change is in Kootenai County. So if we take those statistics and apply it to the county request, we have 3.74 for Benoit is their pro rata share. That equates to 32,391. Bonner share 160,101. Kootenai 585, 989, and Shoshone 44,804. So a total of 866,438 of the 1,237,000 is based on population. The valuation allocation is a total of 371,332. 8,700 for Benoit, 91,500 for Bonner, 13,800 Boundary, 244 Kootenai, and 12,690 for Shoshone. How that looks in total when you add the two together. Benoit's share for fiscal year 22 will be $41,140 compared to last year of $42,157, a decrease of $1,017. Bonner County decreases by $5,293, and Boundary increases by $1,666. Kootenai increases by $5,612, and Shoshone decreases by $968. Basically, the shift and drift because of the population change and the valuation change. So here we have our percentage change in county funding over the last 10 years. And over the 10 years, it's actually the same as it was last year. The 10-year average is a 1.65% increase. You'll see that in fiscal year 22, we're asking for 0, as we did in fiscal year 20 and fiscal year 2019. So this is the impact of inflation from 1990 to 2022, 32 years. And I've kept it at 1990 because that's what we've been comparing for a number of years, just for consistency. I've stayed the same. So in 1990, the population was 123,500 compared to 2022 of 247,000. The budget in 1990 was 2,781,000 compared to 14,191,000 for fiscal year 22. So if we take the 1990 budget and inflate it, and according to the Consumer Price Index, $1 in 1990 is now worth $2.04. So that 1990 budget of 2,781,000 would now be 5,674,000 compared to our $14,191,000 budget for fiscal year 22. If we adjust that per capita, that's $45.95, $46 per individual in 1990 compared to $57.42 in fiscal year 22. So you can see that in fiscal year 22, the county portion is $5 compared to $9.26 in 1990. So the county was contributing significantly more than it is today. The state contributed $6.43 compared to today of $5.26. And then other are fees and grants. In 1990, it was $30 per individual compared to $47.15. So what this is telling us is that the district is able to support itself more through grants and fees. So here's our pie chart. When we take our budget and look at our funding sources, here's what it looks like in a pie chart. 50% is contracts. Bright pink is our fees, 31%. 9% is the county funding, 9% is the state funding, and then just a very, very, very minute portion is related to interest and donations and other income. And that brings us back to our budget of $14,191,000. Mr. Chairman, are there any questions?
Any questions? Looks like we'll have you all ready to go.
So we're assuming the state would still be providing 9% for 22? Okay. All right.
I did,
That's a big question mark.
You were supposed to tell us that in your trust.
Mr. Chairman,
Yes.
thank you. Glenn, this is where, all the districts have, because we have to do this, get the budgets in by a certain date for Idaho. And since we just don't know what we're doing, and if we need to come back to the drawing board and, revise the approved budget, we'll certainly do so.
It's understandable. Thank you.
Mr. Chairman, I did go ahead and increase the fuel as you had suggested. So that was taken into account. And I think that was really the only other change. Yeah. That got driven up a bit.
Okay. Yes, Dr. Banks?
Yeah, Christine, you mentioned that you expected the clinical fees to increase. Why is that?
Well, during 2021, fiscal year 21, We saw a decrease related to COVID. We didn't have the activity, we couldn't have the traffic in
So
clinic.
people were not coming in here,
People were not coming in.
but you anticipate they will come in.
We're hoping that they will, so we budgeted accordingly.
As things get back to normal, yeah.
I can't wait. Okay, any other questions or comments? We do need to take some action here today. And the action we want to take here is a definite maybe.
Based on the information we have this time.
Yes.
So, Mr. Chairman, based on the information we've reviewed and discussed, I would make a motion that we approve this proposed budget for FY '22.
Thank you. Is there a second for that motion?
I'll second that.
All right, and seconded down here. Any other discussion on this motion before we vote? It's hard to discuss it. All right, all in favor of the motion as stated, indicate by saying aye.
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 And opposed, no. Thank you, Christine. You have a action on this, and we'll see what happens.
Thank you, Mr. Chairman.
Indeed. All right, we'll move on to our director, who is going to share her work with us at this time. Nice to have you back, almost in one piece.
Thank you, Mr. Chairman. Jumping around a little bit, certainly I appreciate your approval of this budget for presentation to our budget committee. And a reminder that our budget committee is made up of the chairs of the 5 county commissions. It's on a rotating basis who chairs that budget committee, and this year it will be Clotting County, Chris Filios, Commissioner Filios. That will be immediately prior to our board meeting at 11 a.m. on 27 May. So I'm hopeful that you can all be here either via Zoom or in person. We will be doing our rounds to the commissions to present this budget, so they'll have a good idea of what's going on when they come to the budget committee and able to discuss it prior. We'll be in Benawah County this coming Monday at 9:30. Boundary County, Commissioner Denning has asked that we call in, so we'll be doing a call in presenting this information. Shoshone County will be in person, and the Boundary County, that will be also Monday at 1:30. So Wednesday will be Shoshone County, we'll go there in person, that will be at 11 a.m. And Tuesday, going back a day, 27 April, at 1 o'clock, we'll be in Clotting County, and Thursday, we will go in person. They gave us the option, and we chose to go in person to Bonner County. That's gonna be at 9 a.m., and Glenn is unable to attend. Dr. Banks, if you're able to attend, I'd greatly appreciate it.
That's Thursday, the 28th,
29, sir,
29th.
at 0900.
0900.
So, with that, the Idaho Association of Boards was able to speak with the director of District 5 in Twin Falls, Melody Brower, and they are holding a hybrid meeting this year. They came up with the time because they could not agree on how long the meeting would be. It's just going to be a business meeting, so I would imagine it won't go more than 2 hours, but that is going to be 17 June. Beginning at 12:30 our time. So what I would propose is if you would all like to come here, either via Zoom or in person, that would be great, and we can meet then. If you would let me know, we will certainly provide refreshments, and we'll have it here in the Show Ben Room, 17 June at 12:30. The meeting will start. District 5 is hosting. As you're aware, the Clotting County and Benawah County positions, not the at-large, but the county commissioner appointed positions, Jay Nelson's and our chair Marlo, 5-year terms were up. Benawah chose to renominate Marlo. And Jay has chosen not to seek renomination. So Kootenai went ahead and solicited interest via or via however they do that. And they had quite a bit of interest. I think they had 17, 18 interested parties. They went through an interview process. They narrowed those down to 6 and interviewed 6 individuals and selected one name for nomination. So each of the counties should be getting those ballots, and each county commissioner will vote on that individual. And we will open those ballots at our May 27th meeting following the budget hearing for the Benoit position. And again, in Benoit, they chose to only nominate one individual, and that individual is Marlo Thompson. So I think that, Mr. Chairman, concludes my report. Happy to stand for questions.
All right, any comments or questions you have for Laura? Here's your chance.
I assume, Mr. Chairman, we'll be getting email reminders about these upcoming meetings and events.
Reminders.
What are you trying to tell us?
I can't remember everything, Ryan.
I was afraid of that.
Mr. Chairman?
Join the club.
Absolutely, we will send many reminders on that important day, 27 May, 11 o'clock. Oh, and then June,
It
yes.
might be well just to include all of the county meeting dates too.
Right, I will send, or I would ask Jill to send that sheet of all the different county meetings out today, if you would please, to our, yeah, is it in your packets? I don't believe so. Or you have, oh, we have copies, we will hand you hard copies right now.
This is efficiency. All right, is there any other business that needs to come before this board at this time? Any comments, questions, clarifications? Thank you. Thank you, Jay. Thank you, Dr. Papandreou. And one slight correction on my part. I think I mentioned at the beginning of the meeting that Mike was with us. Mike was not with us today. And I'm sure you have that in your minutes. Thank you. We are adjourned.